do have a quorum. Let's go ahead and call the subcommittee to order. First on the list is going to be our chairman, Senator Reeves. That being said, I need a proxy form for myself. So I'm going to leave that with Senator Black, and he will chair the meeting. Okay, Senator Reeves.
Mr. Chairman, I think I have for the committee, Senate Bill 1247, there's amendment in nature of substitute.
Motion on the substitute?
So moved. Second.
Moved and seconded to accept the substitute. Those in favor, please say aye.
Aye.
Those no. Substitute's properly before us.
So, Mr. Chairman, this is a follow-up bill to a bill that I had last year, and you want to go ahead and speak to the bill?
Sure.
What we're trying to do.
There was some misinterpretation.
Who are you, sir?
Bruce Keeney, representing the Association of Independent Funeral Homes of Virginia.
Thank you.
Y'all addressed an issue that Senator Reeves had last year with some legislation. There was some misinterpretation later on this summer. This bill clarifies the intent of last year's legislation, which is already Federal Trade Commission rule and then Board of Funeral Directors, and that is this: as at need, a funeral director must accept a casket and use it from any source. It could be one you made or from out of state or whatever. But the clarification also with this is that pre-need, which is a current law, casket sale is limited to a funeral home or licensed funeral director. That's all it does.
Very briefly, I'm the chairman, so I have to call you Mr. Chairman. All right, so, Mr. Chairman, Mike, isn't this kind of an anti-competitive thing going on here?
So, originally, the original bill was brought to me last year, and this is getting all this is Peace in the Valley at this point, from that bill. I had a citizen in my district that bought a casket at Costa who was a veteran who wanted it to be utilized. He wasn't able to do that. So that's what this bill does, is allow these folks to come in if they purchase it somewhere else, or who knows, maybe they're woodworking and made it themselves, and that's something that they can use themselves. So I appreciate all the entities coming together in the Peace in the Valley. So
Mr. Chairman, actually verifies that there's competition in that new caskets.
Okay. All right, I'm going to leave my proxy with Senator Black. I have got to get to a committee meeting, so.
And I'll be right in.
Okay, thank you.
Okay, let me just ask a question now. So does this cut out Costco caskets?
No.
Doesn't? Okay, I may be.
It actually allows more authority to folks, whether you, like I said, consider you a good woodworker and you want to make your own casket, then funeral home can use that casket to which you have made.
Mr. Chairman,
Okay.
if I may, it may
Yes,
be the confusion of
and
pre-need.
I'm confused.
Okay.
It seems
It may be the issue of pre-need. Pre-need is when an individual, they're obviously alive, they go and meet with the funeral director, make all of their arrangements, they pay for it, and by doing it through there, the funeral home, as part of their package of arrangements, they guarantee and trust that casket at 100% plus the CPI. Okay? The only way that can be done, the only person that can do a pre-need funeral arrangement is in fact a funeral director. So that's what it clarifies. So there's a difference. At need is when somebody's passed and you don't have a casket and you go to the funeral home, or you bring your own or order it, whatever, and it clarifies that the funeral home must accept it, which is current law, current rule, current FTC rule.
okay. So you can get a casket from basically anywhere, I guess.
Yes, sir.
Even homemade, if you
Or
want.
at need.
Once somebody's passed away. Okay. Do you have any other questions? All right.
I have a question.
All right.
I don't follow the necessity of the bill. I mean, I've heard everything you said, and what you've said has been clear, but I still don't understand why this ought to be the posture of the Commonwealth. This is something I didn't hear about from anyone in my district, and usually whenever there's things related to funerals, I get to hear from those folks. The only folks in my district that contacted me were folks that were against this bill. I had 2 individuals who took it upon themselves to email me and tell me why they thought this bill was anti-competitive. So, which is, you know, those are real emails, which are interesting rather than like the list ones. How they found out about your bill, I don't know, Senator Reeves. But can you just explain to me, you know, I'm inclined to vote no unless I think something ought to be the policy of the Commonwealth. And I'm still not there on why this ought to be the policy of the Commonwealth.
If I may help. Board of Funeral Directors have regulations, and the FTC rule for some years says very clearly, legally, a funeral home must accept a casket from any third party. So if you made one, if you bought it from Costco, if you bought it at a Salvation Army store, whatever, and at need, when somebody dies, the funeral home must accept that and use it, okay? What happened was that Senator Reeves had a situation where a constituent called up the funeral home and said, I have my own casket, and they said, no, I'm not taking it. And we met with him and said, that's illegal. And his concern was, well, how would any regular old person know that it was in a board regulation or the FTC rule? So what we worked out was, is we put into the code the FTC rule that very clearly says that. In the process, to avoid a piece of pending litigation that nobody really knows where and if it really existed, the board's legal counsel from the AG's office went into executive session and had the board pass this wide interpretation of the law y'all passed. And the net effect of it was, is it additionally said that anybody can sell a casket at pre-need, which you can't do unless you're a funeral director, but more importantly, it would also create a question as to whether or not people in planning for the future would unknowingly end up purchasing a pre-need casket that wasn't guaranteed or trusted. Okay. So what we were, all this really does is put into effect what the current law is, has been, as well as the FTC rule. It changes nothing, if anything. In reality, there was a great question as to whether or not casket stores in Virginia would be allowed. This also would allow casket stores in Virginia, which may have been, there was one interest in that in Roanoke Valley a year or 2 ago. But this would in fact boil down to that anybody has a casket, no matter where they get it. The funeral home at need has to accept it and use it.
Mr. Chair.
Does that help?
No, and it might just be the recipient of the information is the problem. But when it says no person except a licensed funeral service establishment or funeral service licensee shall offer for sale or sell a casket when pre-need arrangements for funeral services are being made, including pre-need funeral contracts and pre-need funeral planning, it's just, you know, what I'm reading sounds different than what is being described. And I don't know if that's just failing of mine.
If I may, pre-need funeral contracts, pre-need funeral planning are all defined in the code as pre-need arrangements, funeral arrangements by a funeral director. Under the definition.
I don't know where the rest of the subcommittee is. I'd like to hear from them because maybe someone else can illuminate this for me.
Let me, if I could ask a question.
Yes, sir.
I understand what you're saying about the at-need arrangements and that apparently at need you are clarifying and expanding it. I mean, not, I guess it's federal law, but you're expanding state law to correspond. But I think it's section A. Is that somehow a restatement of existing law in subsection
Yes,
A?
what that does is, if I may, Mr. Chairman, what that does is corrects the misinterpretation of the Federal Trade Commission rule and the current Virginia law that was made by the Assistant Attorney General.
I see, okay.
That's the whole purpose of this, frankly.
Do we have,
So, Mr. Chairman,
Yes.
just to put it in layman's terms, so before people would go and they feel they would like, they would have to, when they go to the funeral home, they're going through the grieving process and all these other things. Sometimes, and I'm not saying all of them are like this, but they get stuck buying up something maybe they can't afford, or maybe, there's other options or whatever, and they didn't know that other options were out there. And so that's why we originally brought the original bill, was it last year?
Last year.
Last year. And so, as that bill has matriculated through, there were some other concerns from funeral home directors that they need to clarify this the way we're doing it now. And so that's the genesis of the bill.
okay, do we have any further questions?
No, I'm ready to move.
All right, yeah, well, let me ask first, do we have any opposition to the bill? Do we have any other supporters of the bill?
As all three funeral home associations, the morticians, the Virginia Funeral Directors Association, and the independents all support the legislation.
And we didn't originally, so this is the
Okay.
compromise.
Okay, do I have a motion?
I move to report.
Okay, I have a
Recommend
motion
report.
to report, and,
I'll second that motion.
okay, and a second. All in favor of that motion, say aye.
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 I'm gonna abstain.
Okay.
Hopefully I'll be smarter and figure it out in the next few days.
You get a 5-gallon bucket to be there.
And that'll be the least of my concerns then, so.
Okay, so we have 2 ayes and an abstention, so.
What about the chair?
You have a proxy.
You have a proxy.
Oh, I have, that's right, okay, and I will vote that on behalf of Senator Cosgrove as an aye, so we have 3 ayes and
What a confused person.
a mystified abstention.
Thank you, Mr. Chairman.
Okay, thank you, Senator Reeves.
Thank you, guys.
All right. Okay, let's see, Senator Chase, present, not present. Okay, so Senator Boysko.
Thank you.
As long as you leave a proxy.
Yeah. What constitutes
As long as
You could
there
have
are
all
no votes.
proxies and
Right,
combine.
you could have one person as long as there are no proxies.
Absolute power corrupts absolute.
Okay, so you.
Back in the day.
I don't know who he's drawn into, one of us.
I'll leave it to the chairman.
That's good. After that last vote, he did. I wouldn't
He'd be
have
confused.
Okay, Senator Boysko, why don't you, go ahead and present your bill?
Thank you, Mr. Chairman and members of the subcommittee. Today I present SB 1643, which eliminates the requirement that a person provide a court order indicating that their sex has been changed by medical procedure for an amendment of the birth certificate to reflect the change of sex. Currently, the code provision reads that upon receipt of a certified copy of an order of a court of competent jurisdiction indicating that the sex of an individual has been changed by medical procedure, and upon request of such person, the state registrar shall amend the person's certificate of birth to show the change of sex, and if a certified copy of a court order changing the person's name is submitted to show a new name. With this bill, to amend the provision, the Commonwealth will move toward reflecting the current scientific understanding of gender, which does not necessitate medical procedures such as surgery to establish gender. The current scientific consensus separates gender identity from anatomical expression. While individuals can choose to have surgery, it is not required. The burdensome requirement of providing a medical procedure not only violates an individual's privacy and autonomy, but also has a disproportionate socioeconomic repercussion. Surgery is expensive, not always covered by insurance, not widely available, and requires a long and painful recovery period. Even if an individual wishes to have a gender-related medical procedure, they may face extreme obstacles obstacle, or reason should not prohibit an individual from amending and correcting their birth certificate. Accurate and consistent IDs are necessary to open bank accounts, start new jobs, enroll in school, travel, as well as other routine processes. Virginia's current law for changing sex on a birth certificate includes an intrusive and burdensome requirement, proof of a medical procedure and a court order, that has made it impossible for some people to update their IDs and accomplish many tasks. By contrast, all that is required for a transgender person to have their Virginia driver's license, their social security records, and U.S. passports reflect their true gender is a letter from a doctor confirming that the person has gone through appropriate gender transition related medical care. This bill serves to align the birth certificate amendment process with other major document procedures already in place. It will also protect transgender individuals from the known negative results of gender incongruent identification, such as denial of employment, housing, public benefits, harassment, and violence. This step will make life easier for transgender people in Virginia. The Commonwealth does not benefit in any way from making birth certificates contingent on a medical procedure, and we should eliminate this arbitrary requirement that puts the safety and security of some of our citizens in jeopardy. And I hope it is the pleasure of the subcommittee to report SB 1643 to the full committee. I thank you.
If I could just ask you a question.
Yes,
So we currently have on the books a process for changing gender on a birth certificate. And that current procedure requires some surgical process or procedure in order to obtain the change.
Correct. It requires a certified copy of an order stating that they have had a medical procedure.
And what this would do is say you don't have to have a medical procedure, but you'd have a doctor's statement that there's been some clinically appropriate treatment.
Correct.
So it would alleviate the need to undergo surgery.
Surgery, yes, sir.
That's an interesting situation. Any questions? Okay, do you have, let me ask first, are there opponents of the measure? If you would step up in sequence and identify yourself and then let us know your thoughts.
Mr. Chairman, member of the committee and subcommittee, Josh Hetzler with the Family Foundation. This bill significantly would effectively render one's personhood status as either male or female a legal nullity because there's actually no requirement at all. It sort of gives it to the board, whatever the agency is here, to make those determinations. You'll notice it says that they may require certain things, but don't have to. But then at the end of the amendment it says, but they shall not include any requirement for evidence or documentation of any medical procedure. So regardless of what any of us thinks about the concept in general about whether a person can actually change their sex, you can imagine some of the extreme ways that this could be abused. Someone with only an affidavit, essentially, and changing nothing else, say I'm of the opposite sex, and if they go to prison, let's say it's a male, and they must be put with other women. This is just one of many examples. So I think we got to exercise great pause in making such a drastic change, and for those reasons we ask you to oppose.
Thank you.
Mr. Chairman, members of the subcommittee, Jeff Caruso with the Virginia Catholic Conference in opposition to the legislation. A birth certificate is primarily an historical document, and the main purpose of a birth certificate is to just indicate basic information about a person when they're born, such as their sex. There already is an exception to that in this code section, as was stated, that if someone were to get a court order indicating that a change has been made by medical procedure, then that change could be made on the birth certificate. And while that does take us a little bit away from the historical thrust of a birth certificate, at least that's an objective standard. What we'd be doing if we pass this bill is replacing that with a standard that is, I would submit to you, subjective or vague. And the language here, I think in particular, that really captures that is where it says that they've undergone clinically appropriate treatment for the purpose of gender transition. For the purpose of gender transition, that doesn't even necessarily mean that it's been completely affected. This is just a subjective standard. It creates a lot of uncertainty in the law. It creates a lot of confusion, and we would argue that the current law is superior. Thank you.
Thank you very much. Do we have any other comments? Okay. I have to admit to having some mixed feelings about it. On the one hand, I certainly don't want to see anyone required to undergo a surgical process, but I'm very sensitive to the issue of the prisons. I've done a lot of work with a lot of prisoners in the prisons, and it does concern me if we have a man who is about to be incarcerated for life, and he decides to suddenly become a woman so that he can go to Goochland Women's Prison. For reasons that might not be gender related, well, they might be. I guess they are gender related, but they might be illegitimate. And how do we address that type of thing? I guess I can see people gaming the system for reasons that you don't intend, and some of the men who might do this in the prison system are people that you might very much not want to have integrated into the women's population at the prisons.
Mr. Chairman, I question whether someone would be that crafty to get arrested and then start going through the process of taking hormones or other actions to change their physical presence, looking more like a woman than a man before they go to prison. What I am concerned about are the people who have felt in their bodies that they are of another gender, and I know people. I actually have someone in my family who has gone through this transition, and they really are tortured inside by this. The problem here is that, let's imagine that someone is born in a female body and they feel that they should have been a man, and they go through a transition. They start taking hormones. They've got beards and mustaches. They've got muscles, and on their ID it still says that they're a woman. And they go to a job and they present themselves as a man, and on their ID as they're applying, it said, well, your name is Ernestine. Why are you? It just causes a lot of heartache and burden and difficulty for them. They need consistent IDs to be able to do things like open a bank account, to start a new job, to go to school, to travel. And this is a very complex problem. At the federal level, it is not required. And I feel that it's really important that we certificate, they have the ability to get this without a burdensome surgery. I really doubt that someone would be that crafty to think of trying to sneak into a women's prison. I think the burden on the person who really feels that they are transgender and are struggling with this are the ones who are really the ones at risk of harm. And I really feel that this is a conversation that we need to have to align birth certificate gender policy with other Virginia and, federal major documents. We can do this with our driver's licenses already. We can do this with passports.
I understand what you're saying. I guess, and I, you may imagine where I would stand on the area in general.
I respect that.
But I really am hearing what you're saying, and I really dislike the idea that anything forces or pressures anyone into surgery where you can't unwind what you've done. And I know prisoners, and I know while they might not start off to commit a crime to do this, but once they have committed the crime and once they know, I am dead meat, I'm going in the pokey and I'm gonna spend years of my life there. Would I rather be in there with a bunch of guys or with a bunch of gals? And you don't want to underestimate the craftiness of people who end up in our prison system, because there are some very crafty people. And so I tell you, my concern is more for the unintended consequences than anything. But in any event, do we have any other comments, thoughts before we proceed? Yes, would you come forward?
Hi, Senator Black, members of the subcommittee. My name is V. Lamnick. I'm the Deputy Director of Equality Virginia. I'm here today to speak in support of Senator Boysko's bill. The bill removes the surgical requirement and the court order requirement when requesting a gender marker change for the Virginia birth certificate. It follows policy which is recommended for transgender individuals and health experts nationwide, in fact worldwide, including the American Medical Association and the American Psychological Association. Appropriate treatment for gender transition is determined on an individual case-by-case basis, and it is the private information between a doctor and a patient. Court orders are expensive and complicated to attain, and judges and state courts do not consistently grant orders for gender change. So this bill modernizes an outdated statute which helps to streamline and standardize this policy. This makes Virginia birth certificate policy consistent with Virginia driver's license policy and federal government policy, as the Senator has already stated. We appreciate your consideration and support of this bill.
Thank you very much. Please come forward.
Good afternoon. I speak to you today on behalf of my transgender patients. I'm a registered nurse myself, and I'm studying to be a licensed nurse practitioner. And I'm also currently a psychiatric provider on an inpatient unit at the University of Virginia.
Let's see, could we have your name, please?
Yes, and my name is Dallas Dukar. Dallas Dukar.
Okay, thank you.
I also serve in the transgender clinic with the Teen and Young Adult Health Clinic at the University of Virginia. I speak to you today about how important it is for my transgender patients to have access to updated and accurate identification to live their lives in accordance with their gender identity. This is particularly close to my heart because I too am a transgender female, and I have had my application for my birth certificate change rejected multiple times. Personally, I can say the experience was insulting and degrading. I cannot imagine what it's like for more of my vulnerable patients. According to all medical experts, there is more than one way to transition. Some patients undergo mental health care, others include hormonal replacement therapy, some include surgical treatment for a variety of reasons. However, just as every heart problem does not require heart surgery, not every instance of gender dysphoria requires surgery. Instead, we strive to meet the patient where they are and work with their individual needs. Our state policies should support accessible updates to gender markers for transgender people so that they can go about their daily lives free of harassment and discrimination. Many of our state institutions, such as schools, workplaces, and government agencies require a birth certificate. And a birth certificate that is not updated results in an outing outcome, which can put them at further risk. The bottom line is if we wish to foster a healthier and a happier Virginia, we must start by supporting this bill. I urge you to support SB 1643. Thank you very much for your time.
Thank you very much for coming forward. I think we have heard the bill. Do we have a motion?
You've got the motion and second over there either way. I only have one, you have three. What?
Okay, I won't impose on you to make the motion then. I will make the motion to recommend PBI, and I have a second. It'll be John Cosgrove who will second that.
I just have one question,
Yes.
before, I guess any theoretical discussion that will occur between the subcommittee members. This is an interesting experience, by the way, to be on a subcommittee with so few members. Is there anyone from the administration that has anything to say about how things have been working? I expected I was gonna hear from the administration.
Okay, well, let's just strike that for that now. If we've got one more person coming forward, please come up and identify yourself if you would.
Hi, I'm Janet Rainey. I'm the Director and State Registrar for the Division of Vital Records with the Virginia Department of Health. And at this time, the administration has no position on the bill.
Okay, thank you very much. All right, any other questions? All right.
No, but that's what I was most interested in hearing, the administration's view on that.
Sure, okay. Okay, so we have a motion to PBI with sympathy for what you are trying to do. Second by Senator Cosgrove. And all right, all in favor will say aye.
Aye.
And I am going to, let me see, hold on just, let me see, I have some specific instruction here, wait a second. Okay, on 1643, okay, now, okay, and then it will be a no on, for Senator Lewis.
Correct.
Okay. All right, so we have 3-1, and so the recommendation is to PBI, but I very much appreciate your presentation and those who spoke here. I think we just have a little bit of a quandary with how to deal with this.
Well, thank you for the consideration.
Thank you very much. Okay, let's see, do we have another? Yes, Senator Chase. So you have Senate Bill 1226. I think, well, I'll tell you what, because we have so many people in the audience, I'm gonna give you a mic and.
Okay, all right, can everybody hear?
What if the other subcommittee members need that mic?
Oh, shoot. They can use yours.
I only have one, so just so you know, I'm one vote, over here you have one.
That's right.
I'm not sure.
All right. Thank you, Mr. Chairman and members of the committee. I bring to you today Senate Bill 1226, involving community paramedics. This bill was brought to me by my local Amelia County paramedics, my EMT agency that runs EMT services out of Amelia County. And what they've noticed, and we notice this in a number of our communities, I know my daughter's an EMT as well, is that there's a lot of time where they're waiting around for an emergency to take place. And so they're being proactive and they're saying, instead of just sitting around, we can actually go out into our community, specifically in this case Amelia, where they have a lot of elderly residents, and basically do well checkup visits, meeting with people where they are taking care of the community. We see this across the country. Community paramedics actually help people comply with their physician's care plan and adhere to healthy lifestyles, ultimately reducing hospital admissions and saving the Commonwealth of Virginia millions of dollars annually. Now, when we think of EMS, we think of 911 and we think of emergency services, and that's the extent of it. This would basically community paramedics is a little bit different in that the emergency services is still continuing to go into the home, intermittently checking on its residences who desire or have the most needs. And so it's a little bit different of a model. We're changing, we're having the opportunity to change the model of EMTs. And so it does a couple things. It protects the public by establishing minimum education standards and credentialing for community paramedics, assuring that practitioners have demonstrated competency in the areas of community-based needs, interdisciplinary collaboration, patient-centric care, and preventative care and education, which are not sufficiently covered in paramedic programs. This extends the practice of community paramedics beyond EMS agencies, enabling paramedics to work under the direction of primary care practitioners, specialists, and public health departments by licensing the community paramedic independent of the Virginia Office of EMS while requiring a current certification as a paramedic as a condition of licensure. This exempts entities utilizing community paramedics from obtaining a home health agency license in order to provide non-emergency services to patients as an extension of the patient's healthcare provider. It also provides funding for community paramedic services for Medicaid patients, offering alternative options to emergency department, and extends primary care access to underserved populations and chronically ill patients. Current legislation prohibits the practice of community paramedic programs to the full extent for which they were established at the national level. The Virginia OEMS website provides information about community paramedic services, but offers no direction for implementation in Virginia. However, the Virginia Department of Health has determined that these services are outside of the scope of an EMS agency and do not fit the definition of emergency medical services under Virginia law. This legislation is consistent with that of other states such as Minnesota and Maine, which offer such services and provide funding under Medicaid. And while some MIHCP services are being provided in Virginia, they are unregulated and do not require consistent training to assure positive outcomes for patients. Some entities are using immediate 99 personnel to fulfill these roles, and by defining the educational standards and competencies, licensing the providers with appropriate oversight, and extending the environment in which appropriately trained paramedics can practice. This proposed legislation offers patient protection, improved access to primary care services, alternative treatment to emergency department transport, appropriate funding for patient-centered care, centered services, and improved career opportunities for paramedic practitioners. The term licensure was used initially as some services under Medicaid may require a licensed practitioner. Mr. Chairman, I do have a couple of experts who brought this concern to my attention, that if it would please the chairman to have come forward to speak.
Perhaps just before we do that, so as I understand, right now, we do not have these community practitioners. This would set it up. And as I read the bill, is it my understanding that the board would establish by regulation the scope of practice? In other words, you know,
Right.
somehow we need a definition of what they are
Right.
able to do.
It requires, Mr. Chairman, it requires the State Board of Health to adopt regulations governing the practice of community paramedics.
Okay. All right,
I'd like to call John Dugan.
yes.
Good afternoon, my name is John Dugan, I'm a paramedic in the Commonwealth of Virginia, and that's it. I appreciate the confidence of expert, but I came to Senator Chase with the thought process of, as a long-term paramedic in the Commonwealth of Virginia and across, I'm also, as I say, a recovering Yankee from the north, is the fact that it's a stepping stone for paramedics. And every other place that you go, you want more education, gives you a better opportunity. And the thought process of licensure for a paramedic allows you to advance. So if I'm teaching an EMT, I can tell you you can become a paramedic, then you can become critical care paramedic or a flight paramedic, which is just another certification. And this would be another stepping stone in education. It would also allow the fact that you would have paramedic that was educated here in Richmond, could go to Roanoke and it would be very similar. And you know that that paramedic, if you were to hire me in Roanoke or Northern Virginia, it would be the same, and that was our thought process. This follows a recommendation last year, or 2 years ago in April of 2017, the Federation of State Medical Boards made a recommendation similar to this for licensure for a community paramedic to the House of Delegates. So we tried to create this where it has been executed appropriately. We know we weren't trying to circumvent anything. We have since learned that there are other practices or people in place, or they're trying to work on this at different levels, and I've since learned that. However, I think licensure is definitely the way to go.
Okay, thank you. Of course, we do have midwifery, which is somewhat analogous, I suppose, to what we're doing here. All right, thank you very much. We appreciate that, and we have another. Is this another of your witnesses?
Not in support of the bill.
Not in support.
I think I have one more person in support.
But since we started in support, I'll definitely give you the opportunity.
I had one other gentleman in the back, I think John, who was with you, did he want to speak in support of the bill? You want to come up? Don't be shy now. This is just practice for the real committee. This is a real committee, but it's a This is where we practice.
Such as it is. Such as it is.
This is the public hearing on the bill that I anticipate. That's what I anticipate. So if you want to make your record, Mr. Chairman, if the citizen wants to make his statement on it, now is the time. That's the instruction I've been given to the subcommittee I chair. The public hearing is here. That's why we're here, to hear from you so that we can tell the full committee if we think that this is something the Commonwealth ought to consider or not.
Sure. My name's Daniel Lincoln. I'm a paramedic and a program director for a paramedic education program. I'm also completing a master's degree in public health, and have been doing a lot of research on similar programs like this. You know, when we look at our healthcare system, that 86% of our healthcare expenses are spent on chronic diseases, preventable diseases. 54% of patients are typically compliant with about 54% of their physician recommendations. And only about 50% of patients understand their diagnosis when discharged from the hospital. That's really our goal with this, and my goal as an educator is to kind of advocate for my students and their futures, being able to give them opportunities to better serve their patients rather than taking patients by the most expensive means of transportation to the most expensive place to get care. So this offers us a variety of options to work with any of the 70,000 medical practitioners as opposed to the small group of EMS physicians. It really expands the opportunities for paramedics to work to do more prevention, public health, do a better job for our community, and that's really what our goal was with drafting this.
Okay, fine. All right, do you have any other witnesses in favor before we start with the appointments? Okay, you can step down. Thank you very much for coming forward. Now, if we have opponents, please step forward and identify yourselves in turn, each in turn, please.
Hi, I'm Marcy Tedderton. I'm the Executive Director of the Virginia Association for Home Care and Hospice. I'm also a gerontologist, adjunct professor over at MCVVCU in the gerontology department. I'd like to welcome one of our students here. She's with me today. You want to introduce yourself?
Hello, I'm Kubi Bond from South Korea. I'm a BCU student studying gerontology at BCU. Thanks.
Well, thank you for being here.
People are aging all over the country. I want to thank Senator Chase for bringing this important issue to the committee today. We are opposing the bill, but it is a real issue. We've been meeting with Dr. D, with a group of, and you'll have to help me with the title of the group.
It's the Mobile Integrated Healthcare / Community Paramedic Work Group.
And we've been meeting for about 5 years now on this particular issue. And I think we've come a long ways from where we started from. I will say that community paramedicine is not home health. It does not meet any type of clinical, state, or federal definition of what home health care is. So the notion that they should be exempt from home health licensure, we adamantly disagree with and don't believe it's appropriate for the state to start Christmas treeing exemptions from home health care, because that's care, intimate care that's provided in the home, all the way from activities of daily living to high-tech skilled nursing services. So we really have concerns about that. It's not possible under federal regulation for a unlicensed, uncertified home health care agency to receive Medicaid payments. The bill specifically addresses that, and that's a prohibition of federal law. We also note that one of the questions I believe you asked Senator Black about the scope of practice. Our group has not really fleshed out, our work group has not fleshed out what the scope of practice is, nor is there any consistency from my perspective across the country. Right now, paramedics and EMTs are, paramedics are required to do about a year's worth of education. EMTs, I believe it's about 120-hour training curriculum for that. And that's relatively equivalent to what a certified nursing assistant would receive. So we're taking something that really needs, if they're gonna practice independently and be licensed, there has to be a lot more education and credentialing that goes into their new job responsibilities and scope of practice. Under current regulatory structure, any licensure of a healthcare professional is with the Department of Health Professions, not with the Health Department or with the Department of Social Services. So the notion to put it underneath the Health Department, we believe is also a concern. So we're concerned with some of the issues, but thank you, Senator Chase, for bringing this issue forward.
Okay, thank you very much.
Mr. Chairman, Matt Cobb, representing the Richmond Ambulance Authority. We likewise have concerns with the legislation. We believe it's premature. The EMS Advisory Board has been studying community paramedics. That term means different things in different places. And it is a concept that is starting to spread. Mobile integration healthcare is being looked at. We think it is very premature. It's something that needs to continue to be studied. The advisory board is working on that now. The other piece of this that's of great concern to us is the licensure component. EMS providers have never been licensed in Virginia. They are certified. And there are different levels of certification they can achieve and they can gain. When you add licensure to it, you're creating an entirely new regulatory scheme, and you're creating an entirely new licensure scheme for these individuals. It's not something that we've generally done in this field, and we don't think it's time to do that now with this bill. And so we're in opposition to the bill. Thank you.
Okay, thank you.
Okay. Good afternoon, Mr. Chair, members of the subcommittee.
Did you have a question before we?
I'm ready to make a motion, and if possible, I don't have a sense of the subcommittee, but at least where I am, because there are several other obligations, where lane has to be licensed, and then we go from there. So I started as challenging to convince of licensure in general. I often prefer other processes. I think that this is the sort of thing that if this were the first year of a General Assembly, I'd say that I'd make the recommendation to be motion for pass by for the year. And but because I can't, I'd make the motion to pass by indefinitely. But I think this is something that folks should, everyone acknowledges this thing needs to be discussed, and they meet with Senator Chase and discuss how this might be able to work out in the meantime. I just don't think that we're gonna be in a situation where we're able to get something that I'm able to support, and I don't know where the rest of you are, but that's where I am today.
Well, let's just continue with
So,
the.
but
with
to
the
say that
ways
to the
we
folks
go.
that are trying to convince us it's not a good idea, I'm already convinced of that, so.
Okay, well.
I mean, as of today, the bill, as today, I don't think it's a good idea to pass. That's just where I am.
Okay, well, let's just hear from the other witnesses, please.
So good afternoon, Mr. Chair, members of the subcommittee. My name is Alan Yee, and I'm the Operational Medical Director for Chesterfield County Fire and EMS. And I am here speaking specifically as a member of Chesterfield Fire and EMS, and not necessarily a member of the Governor's EMS Advisory Board. I hold subspecialty board certification in EMS and have been involved in MIH/community paramedic for over 5 years. I also am the chair of the Governor's Advisory Board MIH work group, a Mobile Integrated Healthcare work group under the State Medical Direction Committee. As you all know, community paramedicine programs can significantly vary across the country. Chesterfield Fire and EMS has developed a national award-winning community paramedic program since 2013. So we're over 5 years in having an active program. To date, we have over 1,500 referrals. And looking at the number of calls, we've reduced 911 calls in this select population by 55.3%. We've had over 20, that translates over 2,400 calls per service saved for the 1 year post-discharge from our program. If you look at all the programs year after year after year, we've probably saved over 4,500 calls for service. And each call for service means over an hour of our time on an ambulance and an engine. We facilitated over 40 ramps for our residents in our community so they could live at home. We've also have a arm of our program that looks at opiate addiction. We've had over 207 opiate referrals. We're able to contact over 43% of them. And of those, 68.7% of them have gone on to recovery and rehab. When we designed that program, we were expecting 5%, but we're almost over 2/3 of our patients go on to rehab.
So it sounds like you've got a tremendous program. You're accomplishing a great deal. Are you opposed to the bill?
We are opposed.
And could you say why you're opposed?
So we commend the patient for striving to improve patient care and EMS in general. The bill has several issues that would impact services. Some of these examples would include, but not limited to, the additional burden of creating and maintaining an EMS licensure system. Right? So we're already licensed at the paramedic level. The same scope of practice is the scope of practice. Virginia is a ceiling scope of practice state. So at the State Medical Direction Committee, we dictate what the highest level is that a paramedic can have. So all these skills that Minnesota, Maine, Colorado use, we are well within our scope of practice. The addition of an educational model and board certification is not fully supported by national groups. You know, I have the luxury of sitting on many national committees that address mobile integrated healthcare. When you look at one EMS system, when you look at one community paramedic system, you've only seen one. By pigeonholing us into something similar to the Minnesota model, which works wonderful for them, would not work well for us. Our program, we modeled it after Wake County, which really goes after targeted education. So if we look at opiate abuse, then we're going to give our team members opiate addiction education. If we look at heart failure, we'll give them heart failure education. And we document all this. If you look at the community paramedic model, the community college model, they teach much more of a public health model, which is a good curriculum, but not necessarily fit our mission. All right? And then there's also the ambiguity of if the community paramedic program has to be embedded within the EMS agency. Most of the community paramedic programs that I'm aware of are based out of an EMS agency. If you look at a mobile integrated healthcare program, it's integrated. It could have PAs, nurse practitioners, nurses, and that may be run outside of that. So there's a lot of discrepancy when you look at it as a state. So,
Okay, I think we're gonna probably need to move on. That's an excellent presentation. I do appreciate it. I think we've got one more witness waiting for us.
Thank you, Mr. Chairman. I will be quick. I'm Ed Rhodes. I represent Virginia Association of Rescue Squads, Virginia Association of Governmental EMS Administrators, Regional Directors Group, and Virginia Ambulance Association. And all of these groups are strongly opposed to this bill, and I'll leave it at that.
Okay, thank you very much. Do we have, Senator Barker, you came in, just a little bit, later. I don't know whether you have,
Should we start over again?
No, we tried that the last week.
Okay, would you like to wrap up?
Sure. In conclusion, I would say, first of all, I appreciate all those that came forward. This is an issue that we've actually been working on together. We're continuing to have these discussions. I wanted to give the gentleman who brought this concern to me a full day in hearing both for and against. Obviously, there's still some issues that need to be worked out in this, but I did want to bring all the stakeholders together today and give them the opportunity to have their idea presented before this committee, and also give them an opportunity to meet after this is over and encourage them to collaborate together and come up with maybe a better solution next time.
Well, I very much appreciate what you have done. I tend to be very supportive of moving paraprofessionals to higher levels. It tends to bring costs down for people, but there have been a number of issues raised that are probably pertinent. So at this point, I would ask, do we have a motion? Did you have you had an opinion? Do you have an explicit motion?
Yes, like I said before, that's where that motion I'd usually make if this were a different numbered year. That being said, I move that we recommend the bill be passed by indefinitely, and then outside of that, encourage everyone to talk with Senator Chase about this. So I think she brought some interesting things forward for us to look at.
Do we have, we have a second? All right.
Mr. Chair, just
yes.
comment briefly. This is certainly an intriguing idea, and I think the types of things that are already going on in Chesterfield with sort of implementing things that are consistent with what you're talking about here are paying dividends already. And I think this is the type of thing that is important for us from a population health standpoint to build these types of systems that are there. Like Senator Sutherland, I have some questions as to whether licensure is the category to go, and I do have serious reservations about calling it home health, but then exempting it from some of the licensure things. So I think what has to be done is not abandon the idea. I think you're off on a great path here, but make sure that we figure out the structure and the operation of it that makes the most sense and can be implemented consistently across Virginia in places where people want to pursue this. So,
well, and I would echo that sentiment. I think it's a great idea, and it's probably needs to be fleshed out. But with that, we have a motion to very gently PPI. All in favor, say aye.
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 Okay, and I will vote aye and vote aye with both of the proxies.
Thank
All
you,
right.
Mr. Chairman. And I would ask that the stakeholders meet us out here in the hallway for a quick meeting. Thank you.
That sounds like a good idea. Thank
Nothing
you
like,
very much.
nothing like the present time to get started.
That's right.
Okay.
Chairman, members of the committee, I'm here presenting Senate Bill 1760. And the catalyst behind this bill is when you have Special Operations Forces personnel, both active and retired, going through rehab, they need another way to kind of check on things, going through their progress. And I've got a subject matter expert with me here today that's going to kind of walk us through this. We can do it in a much more elegant, flat fashion than I ever could. So with that, I'd like to turn it over to Cheryl, and we'll go through her background and then walk you through this.
Good afternoon. Thank you for taking the time to hear the requested amendment. My name is Cheryl Zankowski. I'm currently a registered dietitian with over 15 years of experience in the field. There is no federal regulation that limits the scope of a DEXA scanner being used to measure body composition. That said, in my 15 years of practice, I myself have executed over 1,000 scans with various athlete, professional sport, and military members via other states where I was employed prior to the state of Virginia. In the state of Virginia, we were able to utilize the same technology, which is now recognized as the gold standard to measure body composition assessment with military members on military base. However, now going out into private practice in the private sector, the margin of error utilizing other technologies is 5% and greater, which does not give an accurate reflection of changes being made based on dietary, lifestyle, strength and conditioning, supplemental and potentially prescription medication interventions. We would like to utilize this technology in the private sector for those individuals going through recovery programs and those that are retired, gravitating into the civilian sector, to use as a metric for progress and establishment in healthcare as a gold standard. Potentially, it could be limited to healthcare professionals such as registered dietitians, certified athletic trainers, physical therapists, if not any and all parties involved that are trained by the manufacturer, if additional regulations would be considered. Another possibility would be to limit the number of tests to potentially 6 per year. This exam, with the scanner used on the body composition setting alone, completely different from the bone mineral density setting, emits less than 10 microsieverts of radiation. That is the same amount that is exposed to an individual at sea level in a 24-hour period from the sun in and of itself. It is a very small dose. The technology does not require any lead, any special circumstances for those operating the machine, standing around the machine, or for the rooms of the machine. So again, we would like the opportunity to please be considered, even if there are limitations based on those executing the exam or the numbers of exams provided within the given calendar year.
Let me just ask you a question. The language of this, does this limit it to body composition? I notice it does mention that.
50 it does.
Okay. So the bill is strictly limited, and it doesn't pull in anyone other than a body composition. Well, it says body composition scan. Okay.
Sir, if I may, that is a completely different setting and type of scan than anything that is going to diagnose or treat disease. This amendment isn't asking to take anything away from those that are registered, licensed healthcare professionals in the state of Virginia who have gone through rigorous training. Again, not meant to diagnose or detect any sort of disease with regard to bone mineral density, osteopenia, or osteoporosis. This is a completely different utilization of the technology.
Would the terminology be body density composition scan, or is that?
It's not taking an accurate measurement of bone mineral density, because the strength of the x-ray for this specific function is less than that of a bone density scan. It's not site specific, so it's not as strong of an x-ray emitted from the scanner.
So all that this does is to get the density of the non-bone parts of your
So it gives an estimate of bone, but because it is not as strong of a strength, it is not getting a definitive for treatment and diagnosis amount of bone, because it is doing a full body scan, not a site-specific concentration that is required to diagnose and treat disease.
Okay. All right, do we have
questions from members?
Trying to learn on the fly here. What is required of a radiologic technician, et cetera, to be able to administer x-rays through the radiation x-rays that would be different from what you're talking about here?
They are capable of executing these exams. However, I called over a dozen facilities in the general vicinity, and no hospital will actually run them because it would reduce their ability to assess bone mineral density in patients that are scheduled at 15-minute intervals that they are utilizing to claim insurance purposes, etc. So this is not meant to compete with or be used instead of a diagnostic protocol.
Okay, follow-up question here, Mr. Chair. Yeah, I'm not focusing here on the hospitals or the other equipment or things, but it's on the personnel.
They are capable.
So what training do they have that someone might argue should be required in this particular situation? So.
Their training is much more extensive for disease assessment and treatment regarding bone mineral density, whereas this scan is a one-day treatment that you can receive by the manufacturer, and there are dozens, hundreds of research studies that explain what the requirements are as far as non-pregnant individuals, asking those when their last exposure to radiation for medicinal purposes was, if they're on any sort of medication, and then frequency of exam that it doesn't serve a purpose any more frequently than 8 to 12 weeks. Just because its accuracy is so strong that you would just see the same measurement over and over again, a period of time where a lifestyle, dietary, or supplemental intervention would need to run its course for the assessment to actually show adequate change to be positively or negatively reinforcing.
Another follow-up question. Okay, just to make sure I understand this. So what you would anticipate, or what you would do here, since you've already been, provided these in the military setting in other states and everything, is do scans at 8 to 12 week intervals to determine changes in body composition that show whether I'm actually been running as far as I told you I was, or whether I was cheating and not achieving any benefits.
So the length of the program specific to military members is 6 weeks in length. So it would be week 1 and week end.
Okay.
For other individuals who are interested in the scan, it would not be any more frequently than 8 to 12 weeks. That is correct.
All right, thank you.
All right, other questions from the members? Okay, let's see, do you have other people to speak in favor of it? Anyone else to speak in favor of the measure? All right, do we have others to speak in opposition?
Yes, Mr. Chairman and members of the committee. My name is Richard Such. I am a diagnostic radiologist practicing here in Richmond, Virginia. We are speaking in opposition to SB 1760. We take exposure to the population by radiation seriously. As a radiologist, I had many hours of radiation physics and radiation safety training. As the science of radiation exposure progresses and best practices and industry standards evolve, continuing education is essential for patient safety. We are concerned about the removal of supervision. Radiologic technologists, as has been alluded to, and radiology PAs have a lot of additional training and are under the supervision of a physician currently and should remain so. We also object to the simple notice requirement that radiation exposure has risks. I think this will be more confusing than helpful to patients. The person operating the machine should be well versed in the potential harms and critical effects of radiation exposure, not simply telling the patient that there are risks.
All right.
A question, Mr. Chair.
Yes,
Sure.
please.
Yeah, I'm sorry.
Sorry.
Excuse me.
Can someone who's not a licensed radiologic technician perform these types of procedures if there is supervision from someone like you who's a diagnostic radiologist?
Well, I think the people administering the radiation and supervising it should be adequately trained. There's no question that someone can use this machine and expose patients and get the information, but we feel that it should remain under the same requirements of all other uses of ionizing radiation, which pretty standard across the board.
Thank you.
Okay, all right, thank you. Do we have other opponents of this measure? Okay,
Mr.
seeing.
Chair?
Yes.
Is there anyone here from the Department of Health or any state entities that might be able to provide some information to help us?
Mr. Chairman, members of the subcommittee, I'm Steve Harrison, Director of the Office of Radiological Health with the Virginia Department of Health. At this time, the administration does not take a position. I did, however, share with the patron this morning some information concerning the use of the DEXA units for body composition scanning.
Mr. Chair?
Okay,
Follow-up question. Do you anticipate the administration taking a position on this at some point in the next week or so, since we're running up against crossover?
I can't answer for the administration, sir. As I said, I provided the Office of Radiological Health's comments to the patrons.
Okay.
All right, thank you.
Mr. Chairman?
Yes.
I don't, that's not reflection on you, it's just, I've had this administration tell me they were gonna veto bills of mine before they even heard in subcommittee before, so I just would like to, I know it's not your ability to say one way or the other, I mean, someone from the administration, that's headed up by an MD would tell us their thoughts on this. I think that's sentiment of others.
Yes, I understand, and obviously you have to, do what the administration wants. It would be very helpful to us because, you have at your disposal the full panoply of healthcare professions and professionals, and, we are a part-time legislature, and, so when we deal with something like this, we would like to get it right. And so perhaps you could lean into the wind a little bit, not you personally today, but perhaps the administration could look a little bit more closely and if it's a good idea, say so, and if you have concerns, express them. But thank you very much.
I have a question.
Yes.
Not directed at anyone individually, but whoever could answer it. What are other states doing on this? What have other states done?
There are 45 states, a couple who may have shifted one way or the other since the last time I checked, that do not specify who has to operate this sort of scan or technology specific to this utilization.
So in other words, you're saying that in 45 states, it would be possible for you to conduct these body density examinations without any oversight other than beyond what we're talking about here today?
Manufacturer's trace.
Okay. Any other questions?
I guess the follow-up question is, does anyone dispute that that's the situation, that we'd be the 46th state to adopt the policy advocated by the senator and his constituent?
Well, I guess she's saying it's not that they have adopted a policy, it's that they don't have a restriction.
They're not restricted.
But, yes, Mr. Chairman, but no restriction, and this seems to be, so we'd still be with 45 other states, if that's accurate, in not limiting it in the way that we currently do. That's what I meant. I wanna know if Virginia's trend setting, middle of the pack, or if this is something that we'd be late to the game on. This is something I never thought about before this bill came up, which is why, I'd like to know what the administration and other folks think.
Mr. Chairman, if I may, I am certain at this point, if this were to pass out of the subcommittee before full committee, the administration would be taking a position on this. absolutely certain they would be taking a position on this.
That would be helpful, that would be very helpful. Comments? All right, do we have a motion?
Well, I will, just to further the discussion here, I will make a motion to recommend to the full committee, reporting, of this, or to some extent, to sort of get movement in terms of what position the administration has and what we need to do, how we can best address this, both short term and long term.
All right, we have a motion to report, and do we?
I'll second that motion,
Have a
although I
second.
want the senator and his constituent and anyone else to know that I'm interested in knowing more about this, and my recommendation for a report today doesn't mean necessarily that I'll vote yes on Thursday.
Yes.
But for today, I'll vote to help it advance on.
And, all right, I will also vote to report, and I think I'll vote both of the proxies to report. So at that, we'll have, the recommendation will be to report 5-0, and we.
Thank you, Mr. Chair.
Yes.
What I would have, even though I did make the motion to report, to move this forward, I would like to abstain on the vote, so we make it clear that, we're trying to get attention paid, to this issue and, get some more information and help us make a decision here. We're open to the idea here. I think certainly you made a strong case for what you're doing there. You know, obviously I have some concern with the opposition of the radiologist and, you know, the fact that we don't have a position yet from the administration on this, which is responsible for the radiological health.
Okay, so then, the bill will have a recommendation to report 4-1, with the one being an abstention.
Right.
And with great pressure being applied to the Department of Health to come forward with some sort of a position that will help us to move forward in a rational process. Okay, do you have anything else?
Mr. Chairman, members of the committee, thank you very much.
Okay, well, thank you very much. We appreciate you coming. Okay, let's see, apparently we have a motion, or we have a request by Senator Deeds on SB 1478 to strike at the request of the patron, and I shall move. Second.
Just a
Okay.
quick inquiry, just for anyone paying attention. Our clerk received this communication from Senator Deeds' office himself, correct?
Correct.
With that, I'm comfortable in voting
The affirmative to strike.
All right, so we have, that will be stricken 5-0, and then.
We just recommend striking, right?
Correct.
Yes, yes, that's our recommendation. And then finally, I think our final bill then is Senator Barker's 1280.
Yes, Mr. Chair, this should be fairly straightforward. We passed, basically the same bill. Actually, the language that I put into the bill in introducing it, is identical to what passed the Senate last year. We got over to, we made some changes during the process, last year to address some issues. When I got over to the House side, they loved the bill, but they said that, because they had already killed a House version of what was originally submitted, they were bound and beholden never to consider approving this. So, they said, bring it back next year and we'll pass it next year. So that's what we're doing here. I do have an amendment, to address one issue that has been raised, last year in terms of trying to narrow things. What we did do is identify a body that has various credentialing organizations, that are members of it. And in essence, what happened this year was we were told that that was questionable from the standpoint of the Attorney General's office. So
You say the amendment, the
that you
The
were
amendment
looking at
addresses
is
that.
questionable?
No, the bill that we had last year that passed, that made reference to, the International Certification and Reciprocity Consortium. There being an entity in that does credential, community health workers, that having reference to that specific body there, which is not a public body or a state body, was questionable from a propriety standpoint. So what we have here is the language that is, has the substitute, has the memo been distributed?
Mr. Chairman, Senator Worker, I don't have an amendment, but it sounds like you're saying strike shall be a member of the ICNR consortium. So it would read any such entity shall implement a certification
Well, I
process.
have, here's a, okay, I just assumed you read it, so I couldn't, not sure where it came from. So it's under C down at the bottom there. And, so basically C is rewritten from what it was, when the bill was passed in the Senate last year. And what it does is it eliminates the reference to the International Certification and Reciprocity Consortium. And it says that, an individual seeking certification shall submit to the department a completed application and evidence satisfactory to the department that the individual is certified by a department-approved credentialing entity. And the department shall approve one or more credentialing entities. So it gives direction and latitude to the department to identify one or more credentialing entities.
Okay. And do we have a motion on the
So
amendment?
moved.
Second.
Okay, all in favor of the amendment, say aye.
Aye.
And, all right, and aye for the, both of the proxies. So that is accepted. Okay, do we have individuals who would like to speak in favor of this legislation?
They've been waiting patiently all day, so.
I've dropped $30 on parking, so
Well, you definitely should.
Yes, sir. Senator Black, members of the subcommittee. My name's Christopher Nye. I'm with the Institute for Public Health Innovation, and I've been working in the Commonwealth for a little over 30 years now, trying to improve access to underserved populations. This legislation builds on a General Assembly study from 2004 that James Madison University prepared, and I was an intimate player in that report. It specifically picks up on the need for certification for community health workers, and also that as a part of that certification that we've identified some core competencies for community health workers. The biggest change though since 2004 is there's been much more research on the value of community health workers and the role they play in diverting people from emergency departments who are not in an emergency situation and finding them primary care homes, working with chronic disease management and a range of social determinants of health, which often get in the way of achieving the best clinical outcomes possible. I will add too to what Senator Barker's remarks were, that the International Reciprocity and Credentialing Consortium, or the ICRC, had a very narrow scope with substance abuse. So what we're looking at with community health workers is the broader scope of the roles that they play.
Okay, fine. Thank you very much. Yes, ma'am.
Mr. Chairman, members of the subcommittee, I'm Kelly Cannon with the Virginia Hospital and Healthcare Association. Our member hospitals utilize community health workers in a variety of population health initiatives. They find that community health workers improve patient outcomes and patient engagement with their own wellness and recovery. So to that end, we support the bill.
Okay, thank you very much. Do we have opponents of the bill? And do we have anyone from the administration speaking to the bill? Okay.
I am with the
All right.
administration. But I guess
We knew you were hiding
no,
here
my
somewhere.
response is, now I'm Kayla Craddock with the Office of Family Health Services, and at this time we do not have a position.
All right,
But we did provide, just comments to amendments as they were presented.
okay, good, so you're,
If they have been involved and have helped us sort of figure out how to structure this properly here. Mr. Chair, just to follow up and sort of close out the
Yeah.
argument here. What we've seen over the last few years is a tremendous increase in the number of community health workers operating in Virginia in a variety of different settings. There have also, we've seen things in the community themselves and housing developments, things like that, to try to provide support for people in their own communities. But we've also found significant utilization in a number of the hospitals, and they found these to be very successful in helping patients be better prepared to go home and do well once they are discharged from the hospital. We also had one of the leading research entities nationally on this has been VCU, and they've done some studies that have shown extraordinary value to this, so that the benefit that you receive from having these community health workers in a variety of different settings, and it's not limited in terms of what the setting is, far exceeds what the cost is. It's a significant benefit and improvements in health status as a result of that.
all right, you know, we used to have doctors who would make home visits, those are extinct.
What year were you born? So.
I think there may be one stuffed in the Smithsonian Institution, but in any event, I think anytime we can get out of the community with healthcare, it's a very good thing. So, do I have a motion on this bill?
I would be happy to make a motion to report. So,
Motion to report, and do I have a second, or are you so engrossed in your iPhone? I'll make the second.
I will happily make the second for this. We passed something related to this, or advanced something this morning, so, you know, I'm just happy to support the amended bill. I was happy with it the way it was before, but, you know.
Okay, all in favor of reporting, will say aye.
Aye.
And any opposed? All right, and the proxies vote aye and I vote aye. So our vote is 5-0, recommending that the bill be reported. Do we have any other work on the agenda? Okay. All right, thank you very much. That concludes it.